Okay, thank you for this kind introduction. These are my disclosures. And let's start with the definitions. A multi-drug resistance, it's always based on a compilation of all antiretroviral resistance history. That's very, very important. Every test must be included, genotypic, phenotypic, and particularly the clinical history. We don't have a standardized definition, but just to make it clear, complex antiretroviral treatment regimens are those with more than 3 active drugs. Some patients receive more than 3 active drugs, they are receiving a complex regimen. Heavily treatment experienced patients have received a high number of drugs or regimens, and per se, it does not entail necessarily a high degree of resistance. It can be due to drug-drug interaction, simplification, or any other reason. Multi-drug resistance is usually understood as resistance against 3 drugs in different classes, so drugs from 3 classes. They usually will receive complex regimens, but could sometimes be treated with even only 1 pill once a day. And this situation, it's not uncommon. Being a heavily treatment experienced patient is quite common, but multi-drug resistance is not common, but I would say that it's not rare. The main situation we're going to treat now is subjects with limited treatment options. This changes everything, and those subjects are unable to construct a fully suppressive regimen with more than 2 drugs, with more than 2 active drugs. So these subjects are in jeopardy. This situation is uncommon, and these subjects can be in 2 clinical scenarios. The first one is with a suppressed HIV viremia, and physicians will struggle to simplify their regimens every visit. And the second situation is patients experiencing biologic failure. This is a rare situation, less than 0.5% of all our subjects, and they are really facing a real ultimatum, and this can be a life-threatening situation, and it's very, very important to treat these subjects. Important news, subjects with multi-drug resistance can be treated with we said it with even 1 pill once a day. And in the past, these subjects had high rates of biological failure. But in the recent analysis of the US Cynics cohort, they showed that starting in 2010, the rates of biological suppression of subjects with limited treatment options in the past were approaching the rates of biological suppression of subjects with no limited treatment options. So, concept, these subjects can be successfully treated, and it's very important to be aware that you can find subjects with multi-drug resistance in your office, and you have to be aware of the treatments that they are receiving. How can you get multi-drug resistance with the very many available current treatment options that we have today? I would say it's not easy, but you have to struggle a lot if you want to develop multi-drug resistance. It starts with patients who received in the past with mono or dual NRTI treatments, patients who failed with first-generation NRTIs or unboosted PIs, and those who failed with the sequential functional monotherapy when new drugs were incorporated in the past. All these subjects opened the path for developing multi-drug resistance. And obviously, the absence of complete co-formulated regimens in 1 pill once a day facilitated the development of resistance. And you have a common background. There are always adherence issues due to severe social problems, psychiatric disease, addictions. They are old rockers with long-standing HIV infection. Usually, they are complex cases with complicated lives. You have to deal with this. And quite common nowadays, we have adolescents infected through mother-to-child transmission. This is the usual pathway to develop multi-drug resistance. Just one concept that we have to establish is that the barrier against resistance in drugs with a high barrier resistance is lost steadily mutation by mutation. It does not drop suddenly in a threshold, in a given threshold. Here we have the example of the darunavir, which is probably the drug with the highest resistance barrier. And here we have the score of mutations that specifically impact the darunavir activity. This is a compilation of the power and duet studies. And you can see that overall, the response rate of the darunavir was 39%. This is the overall response in all subjects who received the darunavir. But those who had no mutations at all against the darunavir had 72% of viral load below 50 copies at 48 weeks, with only one mutation that went down to 53, with 2 mutations, 37, with 3 mutations, 29. And the comparator arm had a 12% response rate. So we can say that with more than 3 mutations, you have lost the activity of darunavir. Obviously, it depends on the mutation. But what's important now in treating multi-drug resistant subjects with limited treatment options is that there's a steady decline in the high resistance barrier of a boosted PI, and this must be considered when we construct a salvage regimen. So this is like a manual, like a user guide to construct and to deal with this situation. It has not changed. This is a review for 11 years ago. And we said you have to determine the cause of failure. You have to review all previous resistance tests, as we said. You have to review all the treatment history. This is very important. All potential drug-drug interactions. You have to focus on patients' adherence. This is pivotal because if you don't solve the problems with adherence, you're not going to have success in the new salvage regimen. You have to strive to include 3 active drugs. You have to obtain, this has changed, so this is the only change, you have to obtain a tropism test. And always patients with high viral loads and low CD4 cell have increased rates of failure. So these are more difficult to treat patients. And very importantly, you have to try to obtain the opinion and the support of an expert. So try to get an expert advice. So let's go with our user guide. Treating these patients is not so difficult. You have to construct a regimen with 3 active drugs or sum up the equivalent with drugs that have a partial activity. This is not so easy. So we have to perform a precise estimation of the residual activity of every drug. You have to choose the best optimized background regimen, usually among drugs with high barrier against resistance that are twice daily darunavir, twice daily dolutegravir. You will nearly always use TAF FTC, and in some patients, etravirine will still have activity. Among these 4 drugs, we will only avoid every one of them if it's fully resistant, so well beyond 60 points in Stanford database, or if you have a treatment limit in toxicity. And you have to include at least 1 drug with a new mechanism of action and no cross-resistance to what the patient has received in the past. We have 2 drugs nowadays, Ebalisson Map, which is given intravenously every 2 weeks, Forstem Cell, which is given orally twice a day. And we are going to have in the near future Lenacapabee, maybe it's Latrobe, and maybe broadly neutralizing antibodies. And remember that we still have T20 fluvetide if the patient has not failed to this drug before, and maraviroc if the patient has a CCR5 tropic HIV. All these drugs look quite safe. They have been developed in salvage studies, which are quite similar in the characteristics of the patients recruited. And I have to say that we have limited information usually in salvage antiretroviral treatment trials due to the limited number of subjects and the study design. This is an ethic issue that you cannot have a placebo control arm for 48 weeks. That should not be ethical. Okay, so this is the entry process of HIV into a human cell. It has basically 3 steps. The first one is the CD4 cell receptor attachment, where GP120 binds to the CD4. The second step is the second phase of the binding and the binding to the core receptor, CCR5. And finally, in the third step, you get the fusion. This is where many drugs have the mechanism of action. Here we have Forstem Cell in the virus attachment with GP120 to the CD4 cell. Then we have Ebalisson Map directly blocking the CD4 cell attachment. Maraviroc, it's a CCR5 antagonism. And fluvetide, which is directly a fusion inhibitor. Amazingly, these drugs that act so close one to the other one, no one of them have cross resistance among them. This is really nice. So let's go into start with Ebalisson Map. This is a zoo map, so it's a humanized monoclonal antibody. It's an IgG4 derived from the mouse model that binds to the second extracellular domain of the CD4 receptor on host cells. And this is distinct from binding site from the measured histocompatibility class II molecules. It has its antiviral activity by blocking post-attachment conformational changes required for viral entry into CD4 cells. It has no cross-resistance, as we said before, with any other antiretroviral. It has no relevant drug-drug interactions because it's metabolized in situ in the CD4 receptor. And importantly, it has a low resistance barrier. Now, 9 out of 10 patients with biological failure had decreased Ebalisson Map susceptibility due to changes in the B5 loop of the GP120. So this drug has a low resistance barrier and must be protected with other active drugs. This is important. We have a limitation in the study. We have a single study in salvage. It has no control arm, only 40 patients, and of those, only 31 completed the study. So this is a limited information. And the viral load decay was assessed at only 7 days. Subjects in this study had a mean CD4 count of 150 cells. And what they did in this single arm study was in the screening, wait 7 days that were called a control period. And then they added Ebalisson Map to the failing regimen. And they considered this a functional Ebalisson Map monotherapy. And they compared this period to the previous one, which was considered as a control one. As in all the salvage studies done nowadays, the primary endpoint was the viral load decrease at 7 days, the percentage of subjects with more than half a log decay at 7 days, which was 83%, and this was highly statistically significant regarding the control period, so the week before, as we said. The secondary endpoint was the percentage of subjects with viral suppression below 50 copies at 24 weeks. This was 43%. And as you can see, there was an important difference regarding the baseline CD4 cell count. Subjects with less than 50 cells had a lower percentage of suppression than subjects with more than 50 cells. And it happened the same with the viral load decay. This is the overall viral load decay. This is what was seen in subjects with less than 54 cells or more than 54 cells. So importantly, low CD4 cell count at baseline is a marker of a difficult to treat situation. And that must be reminded when we construct the salvage regimen. Okay, let's go to Forstem. This is a prodrug metabolized to Temsavir, which is the active drug, and it's the first-in-class investigational attachment inhibitor. It's active against CCR5 and CXCR4 tropic viruses, and it has no cross-resistance to any other previous drugs. The main decrease was between 0.7 and 1.4 at 7 days in monotherapy study. Let's see the BRIGHT study design. This is the study with the highest number in salvage clinical trials. It's 272 patients that were failing and had only 1 or 2 classes with active drugs remaining. They were randomized 3-to-1 to receive during 8 days active Forstem Cell twice a day, plus the failing regimen or a placebo. And then all the patients changed the background regimen to the best optimized background treatment plus Forstem Cell. The mean CD4 cell count was 99. It's lower than 150, and that's important. And there was also a non-randomized cohort composed of patients with no active drugs, so 0 active drugs. They were non-randomized, they were included in this cohort. It's close to 100 subjects. So again, the number of subjects is very, very high. And they received open label Forstem Cell plus the best optimized treatment. The primary endpoint is the viral load decay. It was 0.8 logs, and the difference between the placebo and the Forstem Cell is highly significant statistically. And among subjects with more than 1,000 copies, there was a mean decrease of 1 log. This is the results in biological suppression up to 2 years. And we can see that in the randomized cohort, the percentage of subjects with biological suppression was 60%. And in the non-randomized cohort, so again, subjects with no active drugs, it was 37%. Amazingly, in the observed analysis, so getting rid of subjects with loss to follow-up, not due to biological failure or toxicity, the rates of biological suppression below 40 copies increased along the study. So at 2 years, this increased to 79%, which is a nice percentage, close to 80%. And even in the non-randomized cohort, again, remember, with no active drugs, at 2 years, up to 60% achieved biological suppression below 40 copies. How to get the most of this drug? And I think this can be extrapolated to all the salvage studies. You can see that subjects with high viral load and low CD4 cell counts had the lowest rates of biological success, 35% with high viral load and the same with less than 20 CD4 cells. So the important message, don't wait too long to use these drugs in biological failure in subjects with limited treatment options. That's very, very important. In the other side, subjects with high CD4 cells, close to 70%, subjects with a viral load less than 10,000 copies, again, close to 70% of biological success. The best way to obtain the best results with these drugs, analyze the number of active drugs in the regimen. The best way in this study was the optimized sensitivity score, including new drugs. And you can see how they are split, those with no one to two or more than 2 active drugs that absolutely impacts the rates of biological suppression, as you can see here. Those with 2 or more than 2 drugs have rates of biological suppression close to 90%. There's a nice CD4 cell count increase at 2 years, 2,000 CD4 cells. This can be a life-saving CD4 cell count increase, and it's very important, and even more than 100 CD4 cells in the non-randomized cohort. And again, this drug has a low barrier against resistance development. Approximately 50% of the subjects who fail develop Forstem Cell resistance mutations. And we have Lenacapabee, which is the first-in-class capsid inhibitor. It looks like a very potent drug which has a multi-site mechanism of action, acting in the capsid disassembly and nuclear transport, but also in the virus production and in the extracellular capsid assembly. It has no cross-resistance with previous drugs. It can be given subcutaneously every 6 months, so this is amazing. The median CD4 cell count was 150 CD4 cells in this study, and what they did here was splitting patients between those who were adherent and those who were not adherent, and that was determined by the period between the screening period and the pre-randomization. If they saw a decline of more than half a log, they considered the patient were not adherent and they went to the non-randomized cohort. Otherwise, they randomized the patient 2-to-1 to go to oral Lenacapabee or placebo during 14 days, and then to go to Lenacapabee every 6 months subcutaneously. This is amazing. The percentage of patients who achieved more than half a log was 88%, and the mean viral load decay was close to 2 logs. And this is a lot. If we compare this with Ebalisson Map, with Forstem Cell, or even with dolutegravir in the Viking studies, this is a top viral load decay in salvage studies. And at week 24 or 26, 73% of the subjects had a viral load below 50 copies, as you can see here. And finally, the last drug is Latrobe. We don't have studies of Latrobe in salvage, but we know that this drug is active against some variants in vitro. It's the first-in-class nucleoside transcriptase translocation inhibitor. It has a long half-life. It's a potent drug, but it's impacted by the mutation M194B, as you can see here. The fold change increases up to 5 times with this mutation. And with every mutation, as you can see here, the addition of M194B increases the fold change. So this mutation impacts the activity of this drug. It's completely inactive, 10 times fold change increase with the insertion in the position 69. And in the other side, it's fully active against variants with the Q141 complex or the K65R resistance against xenophobia. And here you have the stratification with the calculated fold change increase. In blue, it's the activity of islatravir, and you can see that most of the mutants remain below a fold change of 10. At the contrary, 3TC, most of the mutants are completely inactive against 3TC, and in green you have tenofovir that has a lower potency against these variants regarding islatravir. So we have to finish with this. I would say that as a final takes, the incidence of multi-drug resistance has significantly decreased since 2008, and patients with multi-drug resistance, limited treatment options, and biological failure are actually uncommon. Every case needs an individualized approach. It needs time, and it needs acknowledging HIV resistance and probably an expert consultation, an expert advice. There are many new antiretroviral treatment options available with a new mechanism of action, including Ebalisson Map and Forstem Cell, and in the near future, Lenacapabee, which means that the outlook for these patients is really optimistic nowadays. HIV resistance and biological failure with multi-drug resistance obviously compromises the patient health. It can be a life-threatening situation, so it puts the patient on clinical progression, and very importantly, it can be transmitted to the general population, so it's a public health issue. A high barrier to resistance in the optimized background regimen is lost step by step or mutation by mutation and must be rigorously evaluated when you design the new antiretroviral treatment regimen. And finally, in addition to virological issues due to drug activity, it's pivotal to identify and solve any underlying reason for the last biological failure if you don't want that to be repeated in the new treatment. Thank you very much.